Hello, thank you for tuning into my poster presentation. My project aims to explore the barriers perceived by primary care providers that lead to low lung cancer screening rates with low-dose computed tomography. My fellow co-authors and I are from Robert Wood Johnson Medical School of the Family Medicine Department from New Jersey. Why do we care about lung cancer screening? Well, cancer is the second leading cause of death in the United States, exceeded only by heart disease. One of every 4 deaths in the United States is due to cancer. Lung cancer is by far the leading cause of death among males, followed by prostate and colorectal cancers. Among females, lung is the leading cause, followed by breast and colorectal as the leading cause of death in females. In 2011, the National Lung Screening Trial published its significant findings that would change the way we screen for lung cancer. The trial found that low-dose computed tomography, when compared to chest x-rays, significantly reduced mortality of lung cancer in high-risk people. Screening for individuals at high risk has the potential to dramatically improve lung cancer survival rates by finding the disease at an earlier stage when it is more likely to be curable. Early detection by low-dose CT screening can decrease lung cancer mortality by 20% among high-risk population. High-risk population, as defined by the USPSTF, United States Preventive Services Task Force, which recommended these guidelines from 2013 as follow: ages 55 to 80, 30 or more pack year smoking history, current smoker, or quit within the past 15 years ago. As you might know, recent USPSTF guideline has broadened the criteria to age 50 to 80 with 20 pack year smoking history, currently smoking, or have quit within the past 15 years. Despite the data showing decreased mortality with low-dose CT, only 3.4% of eligible high-risk adults are screened. The map here shows the very low rates of lung cancer screening around the country, with the highest rates in the Northeast, which is less than 15%. In this study, we are interested in understanding providers' perspective to improve referrals and overall implementation of lung cancer screening. We recruited 121 primary care providers from internal and family medicine. These individuals were emailed an invitation to participate and then screened for eligibility over the phone. Sample population was a convenient sample recruited from the New Jersey Primary Care Research Network, snowball methods, and internet searches. We collected data through 30-minute semi-structured interviews. We examined knowledge, awareness, and attitudes about low-dose CT and explored barriers and facilitators of low-dose CT within the primary care practice setting. This is an overview of the participating provider demographics. There were 21 providers altogether. Most providers were between 45 to 64 years old of age. 57% were female, 43% were male, 76% Caucasian, 90% non-Hispanic, and most providers had 21 to 30 years in practice. Provider had an overwhelmingly positive attitudes towards low-dose CT. One female provider in academic practice with 13 years in practice stated, "I think it's excellent and is something I recommend in my office as often as it's applicable." Another provider, a male provider in group private practice with 42 years in practice, stated, "The preventive task force recommends it, and I generally go by the recommendation because it's based on good data and it's not really arbitrary." Despite the overwhelming positive attitudes, there were still concerns about risks of low-dose CT. One female provider in group private practice with 26 years in practice stated, "I think it's certainly worthwhile, but I'm personally concerned a little bit about the radiation exposure during the test, even though it's supposed to be lower radiation." Another male provider in group private practice with 27 years in practice stated, "Unfortunately, the risks are again possibly an unnecessary workup or false positive, and once a nodule is found, you're being re-exposed to CAT scan on a more frequent basis." Providers listed multiple barriers to recommending or talking to their patients about low-dose CT. One of the barriers is cost or coverage. A male provider in group private practice with 27 years experience says, we're not really going to be able to recommend it if they don't have insurance to pay for it. While another provider says, so that's a little bit of a problem if you have someone who's 78 and they meet all those criteria, is recommended by the USPSTF but is not recommended by Medicare or not covered by Medicare. Provider also stated limited patient knowledge as a barrier to talking to their patients about low-dose CT. A male provider who's employed by a physician group with 4 years in practice state, probably knowing about the guidelines, that is a low-dose CT. Other barriers contributing to decreased lung cancer screening rates nationally is provider time constraints and limited provider knowledge. It may be knowledge gap with physicians. They may be not as up to date in terms of recommendations, or the recommendations came out, you said, like 2013, so people who are not in academic medicine may not be as aware of it, says a female physician in academic practice with 20 years of experience. Oh, I would probably have to say the physicians are probably not recommending it strongly enough, or lastly, not taking the time, says a female physician in group private practice with 27 years in practice. Another barrier contributing to low lung cancer screening rates is low awareness. A male physician in group private practice with 27 years in practice says, I would say most of it, some people just don't want to know, so now I have to deal with this. A female physician in academic practice with 13 years in practice state, so I think some of it has to do with how things are promoted and how things are talked about in the media and stuff like that, what patients come across, what they see. Providers suggested some methods to increase lung cancer screening with low-dose CT in the clinic. A female physician in academic medicine with 20 years of experience states having it as a monthly goal for quality sometimes can be effective, whereas a female provider in academic practice with 23 years of experience states a joint effort of multiple providers would be more effective. She says, I think it would need to have multiple persons be coming from multiple places, so I think that the more different ways we can approach it, the more likely we are to improve it. A female physician employed by a physician group with 38 years of experience states, if it was easier for me to order it, because I have to go to some screen. What screen was that? I have to go some screen to order it, then it has to go somewhere, referring to simpler way to order tests. Providers also suggested multiple methods to improve providers' knowledge, with a majority of providers agreeing that in-person meetings such as journal club, grand rounds, live CME, and a speaker would be helpful to improve providers' knowledge of lung cancer screening with LDCT. Provider also suggested multiple methods to improve patients' knowledge of lung cancer screening with low-dose CT, with 52.4% stating that paper and website would be best to improve patients' knowledge. Overall, education of patient and providers is needed to increase lung cancer screening with low-dose CT. Most provider names website with paper-based as best method to improve patients' knowledge, while suggesting in-person methods for improving providers' knowledge with lung cancer screening with low-dose CT. With the new USPSTF guideline to broaden the criteria for screening with low-dose CT, this may enhance screening rates in the future. But, as provider has also noted, universal insurance coverage is also needed. Thank you so much for tuning in.